So I'm going to discuss with you two topics today. One is approach to the diagnosis of wide QRS complex tachycardia, and then the second topic is ventricular tachycardia. So basically, wide QRS complex tachycardia is different from supraventricular. We know in the supraventricular tachycardia, the electrical activation of the heart starts at the level of the bundle of Hess or above it. So the spread of the activity is through the normal conduction system. So we have narrow QRS complex, i.e. QRS complex less than 120 milliseconds. In wide QRS complex tachycardia, it originates below the level of the bundle of Hess. Activation is abnormal, so the QRS complex duration is more than 120 milliseconds. There are exceptions, of course. High septal ventricular tachycardia is close to the conduction system, so relatively the QRS complex is narrow and can be between 110 to 140 milliseconds. Why wide QRS complex is clinically challenging? Because it's difficult in making the diagnosis at times. We have diagnostic algorithms, but they are complex and imperfect. We start to see more simple algorithms that one can remember easily, especially in the middle of the night in emergency room. Again, immediate therapy is needed and sometimes can be life-threatening. Medications, if it's given and treated as supraventricular tachycardia, could be harmful if the patient is actually having ventricular tachycardia. So let's start with the first case. A 56-year-old male. He's known to have hypertension, dyslipidemia, ischemic heart disease. He has palpitations and dizziness, and his blood pressure is stable, and this is his 12-lead ECG. Looking to the 12-lead ECG, what do you think he has? Is it ventricular tachycardia or supraventricular tachycardia with apparency or other diagnoses? I see a VTAC there, okay. And VTAC, okay. Why, can somebody explain why you think it is a ventricular tachycardia? Why you made that diagnosis quickly? Okay, I have heard that one, wide QRS complex tachycardia. Excellent. History of, so if you look to the history itself, ischemic heart disease is suggestive, of course, from the beginning that it is ischemic heart disease, but we will know to other criteria. We will discuss it in a minute. So this is actually baseline ECG. If you can compare that one to this one, you see a big difference. Again, I'll move quickly in the five cases because I'm going to come back to them after the discussion and the lecture itself. A 45-year-old lady, she's in emergency room with palpitations, blood pressure 112 over 70 millimeter of mercury, and this is the 12-lead ECG. What do you think? Is it a VT or not VT? I'll give you a second. Give me what do you think the diagnosis then? Okay, see here, supraventricular tachycardia, SVT with apparency. Excellent. So the third case is a 33-year-old lady, has palpitations, and blood pressure is stable. And again, what is the likely diagnosis? This is probably more difficult than the second case. But see, what do you think of this? Is it a VTAC or not a ventricular tachycardia? Okay, so here's slow VT. Excellent. Most of you got it right. Actually, VT. We'll discuss it again later. A 71-year-old male patient with hypertension, dyslipidemia. He has palpitations and dizziness. Blood pressure 150 over 75 millimeter of mercury. Is this ventricular tachycardia or not ventricular tachycardia? Okay, I see one response VT and the other is not VT. So what do you think the cause if it is not a VT? AF with apparency. Excellent. We'll come to that, inshallah, also. This is actually, I think everybody would know this one. 23 years old, palpitations and dizziness. Blood pressure is stable. I think everybody should get this right, because I'm sure you have seen many ECGs like this. Very excited, AFib. Excellent. So let me go to the talk, then we'll come back to these 5 cases. So to note the differential diagnosis of wide Caras complex tachycardia, if you go to the basics, when we have wide Caras complex tachycardia, even without knowing the history of the patient, it is likely to be ventricular tachycardia in 80% of the time, likely to be a supraventricular with bundle branch block apparency, whether it is pre-existed bundle branch block or rate-related bundle branch block in 15% of the cases. It could be a conduction down accessory pathway, antidromic tachycardia in 1.4% of the time. It could be others, like hyperkalemia in less than 1% of the time, or about 1 to 2% of the time. How to approach patient with wide Caras complex tachycardia? First, start with medical history. Then physical examination in emergency room. There are certain things that can shift you to think about VTAC or supraventricular with apparency or other differential diagnosis. Analyze the ECG during the tachycardia. And if you have the baseline ECG, it's important to compare it to the ECG that you have. So basically, history is important, physical examination. And when you analyze the ECG during tachycardia, it is wide, because I'm just dealing now with wide Caras complex tachycardia. I think if it's regular, you have differential diagnosis. If it is irregular, you have another differential diagnosis. Look for AV dissociation, fusion, or capture peak. Compare it to the baseline. Adenosine can be used in certain cases, but not all the time. But my general approach that I use, because algorithms will come over them just for your own information, but what I usually do is look to the ECG. Is it classic right or left bundle? If it is classic, then strongly think about apparency, like the case I showed you, and then look to the other features like the Caras complex morphology, AV dissociation, capture, fusion beat, and then algorithm. So algorithm is not actually, in my mind, the first thing to think about. So clinical history. If the patient is old, 50 years of age or older, if there's structural heart disease, this is very high sensitivity specificity that the tachycardia we have is a ventricular tachycardia. Again, if the patient has previous history of ventricular tachycardia, the wide Caras complex we have is more likely to be ventricular tachycardia. The opposite, in young age, absence of structural heart disease, previous history of supraventricular tachycardia, we should think more that the diagnosis is likely to be supraventricular tachycardia with apparency and not a VTAC. In physical exam, jugular cannon A waves favors VT, of course. Variability in arterial pressure or first heart sound is favoring VTAC. Hemodynamic instability does not actually favor VTAC or SVT. It can happen in both. We've seen SVT cases with hemodynamic instability, and we see VTAC cases who are hemodynamically stable. So hemodynamic instability cannot differentiate between VTAC and other differential diagnosis of wide Caras complex tachycardia. Okay. So when we have a tachycardia in general, we look initially, is it narrow or wide, regular or irregular, absence or presence of P waves. So the talk today is about wide Caras complex. So we will be between two things. Either it is wide and regular, which most likely monomorphic VTAC, as I mentioned, 80% of the time, SVT with apparency, or antidromic, or others like hyperkalemia or sodium channel blockers. If it is wide and irregular, we have differential diagnosis of atrial fibrillation with Wolff-Parkinson-White accessory pathway, or atrial fibrillation with bundle branch block, or polymorphic VTAC or hyperkalemia. The ECG algorithms has been developed over the past 45 years, and the aim is to facilitate the diagnosis and differential diagnosis of VTAC and supraventricular tachyarrhythmias. It started with Whelan's criteria in 1978, then Brugada algorithm 1991. Then we have the bundle branch block or graft algorithm 1994. The AVR published initially 2007 and modified in 2008. Ultra simple Brugada criteria in 2010, or the R wave to peak time. in 2010. Then we have the VT score in 2016 and the Basel algorithm in 2022. I'll go quickly over them. Some of you maybe are using it in emergency room when they see patients with wide Keras complex tachycardia, but you can see especially the classic ones, the Brugada and the AVR initial one, that they are a little bit complex and sometimes difficult to remember, but we have more simple ones. And then I'll go to what I usually do with the cases that I showed you before. So the classic Collins criteria, it is in patient with a ventricular tachycardia without antiarrhythmic drug use, without antiarrhythmic medications. So it cannot be used in patients who are using antiarrhythmic medications. They include 100 patients with ventricular tachycardia and 100 patients with supraventricular tachycardia with apparency. And basically, the classic same thing, if you have AV dissociation, capture or fusion beat, negative or positive concordance, tachycardia narrower than sinus, the QRS complex, this is more likely to be ventricular tachycardia. If you have right bundle branch block, QRS complex with more than 140 millisecond left axis, this favors VTAC. In the criteria for V1, V6, just remember, if it is not typical right bundle, then it is favoring the VTAC. In left bundle configuration, if the QRS complex more than 120, more than 160 milliseconds, and right axis, this favors VTAC. If the initial R duration in V1 more than 30 milliseconds, or the beginning of QRS complex to the nadir of S wave is more than 70 milliseconds, this favors VTAC. Slurring or notching and the downstroke of the V1 again favors VTAC. In any Q wave in V6 favors VTAC. So basically, AV dissociation, as you know, we have wide QRS complex tachycardia. We start to see P waves marching through, indicating that the atrium is activated by the sinus node. The ventricle is activated from the ventricular focus. So again, this is a hallmark of AV dissociation and ventricular tachycardia. If we have narrow QRS complex in the middle of the wide QRS complex, capture beat, again indicate VTAC, indirectly indicate AV dissociation. Fusion beat, it is a QRS complex that is not as wide as the VTAC or QRS complex during VTAC, and not as narrow as the native QRS complex, so it is something in between. There is merge of activation from the sinus node going down the AV node, and from the ventricular focus activating the ventricle. The concordance, looking to V1 to V6, if they are negative, this is negative concordance. If it is positive, it is positive concordance. Again, this favors ventricular tachycardia, and we'll discuss it in a minute. In the Brugada algorithm, they look to 348 patients with ventricular tachycardia, 170 patients with supraventricular tachycardia and apparency. They noticed that patient with SVT with apparency, they always have RS in at least one of the pericardial leads. So if this is absent, this is specific that this is ventricular tachycardia. So absence of RS in pericardial leads, this is the first criteria. It is specific but not sensitive, as you can see. It is only 20% sensitive. If it is not there, it does not rule out VTAC. So we look to the second criteria, measuring from the beginning of the R to the S. If it is more than 100 milliseconds, this is again specific for ventricular tachycardia. Specificity is about 66%. If not, we look for AV dissociation. This is more specific. If no, then we look to the morphology criteria for VTAC. If all negative, then we are dealing with SVT with apparency. In the Griffith or typical bundle branch criteria, if you have typical right or typical left bundle, typical right characteristically have RSR in V1, slurred S wave in V6, and the R to S ratio in V6 is more than 1. If you have this typical right bundle, this is almost always a supraventricular with apparency. In the left bundle branch block, if you have the small R, deep S, or QS in V1, and you have the RSR in V6, this favors, of course, supraventricular apparency, because this is typical left bundle. You cannot have the typical bundle with ventricular tachycardia origin. Its sensitivity is about 90%, specificity about 75%. So what I usually use, I use this as initial part Then I look for other criteria for VTAC. The AVR criteria published in 2007 initially looked at if the AV dissociation is there, this is a VTAC. Initial R wave in AVR, again, if it is there, because normally we don't have positive initial AVR. AVR is always negative. If it is positive, this favors VTAC. Then we look to the criteria for the bundle branch block and fascicular block. If the KRAS complex is unlike bundle branch block or fascicular block, this is a VTAC. If not, this still, we don't know the diagnosis, then we go for the measurement of the vertical voltage in the initial 40 milliseconds of the KRAS complex compared to the voltage in the terminal 40 milliseconds. In the supraventricular tachycardia, it starts with activation in the septum, then it spreads abnormally. So the initial part should be narrow and the terminal part is wide. Opposite to ventricular tachycardia, where the activation is abnormal, even the initial part is very wide. So if the ratio between the initial voltage to the terminal voltage is less than 1, i.e., this part is slow conduction, this favors VTAC. If it is not, it favors supraventricular tachycardia with apparency. In studies that look to the sensitivity specificity of Brugada compared to the AVR criteria, sensitivity is high, but the specificity in both about in the 70s. The modified one, they look to 351 patients with ventricular tachycardia, 132 with supraventricular tachycardia. And then they looked out to the AVR. If there is initial R wave in AVR, this is a VTAC. If the initial R wave or Q wave in AVR is more than 40 milliseconds, again, this is a VTAC. If notched, down limb and negative onset, and the predominantly negative KRAS complex, again, this favors VTAC. Then they look to the V initial to the voltage initial to the voltage terminal part of the KRAS complex. And if all negative, it's SVT. If one positive, this is a ventricular tachycardia. Okay, the ultra simple Brugada criteria published in 2010, they look only to the R wave peak time in lead 2. So in lead 2, measuring from the beginning of the KRAS complex to the peak time, if it is more than 50 milliseconds, this is diagnostic for ventricular tachycardia. So it is more simple than previous criteria. The VT score system published in 2016, I wouldn't bother you with this one, but they actually look to these criteria and they put a point for each. AV dissociation is 2 points, other criteria is 1 point. If it is 3 or more likely to be VTAC, 2 or more, still likely to be VTAC, but not as strong as 3 or more. So that is the scoring system, rarely used, to be honest. The latest published criteria in 2022 is the Basel algorithm from Basel University. So they look to if the patient has structure, and actually this is different in this algorithm compared to the previous one, that it includes the history part. So if the patient has structural heart disease, myocardial infarction, or congestive heart failure, or already had device, ICD or CRT, this is 1 point that it is likely VTAC. Looking to lead to time to the first peak, whether positive or negative, more than 40 milliseconds is 1 point. In AVR, if it is the time to first peak, again, more than 40 milliseconds, this is another point. Patient with 2 or more, they have VTAC. If it is 0 or 1, it's likely to be supraventricular. So this is more simplified. Structural heart disease, look to the lead to time to the first peak. AVR, time to the first peak, 3 points, 2 or more VTAC, 0 or 1, likely to be SVT. There are limitations for all of these algorithms. You cannot use it in patients with bundle branch reentry tachycardia, which is common in dilated cardiomyopathy patients, not helpful in patients with fascicular VT, and not in patients with accessory pathways. By the way, management, I know you know them well, and this is from the ACLS. So we have a wide KRAS complex tachycardia patient. It depends on hemodynamic stability. If the patient is hemodynamically unstable, regardless of what we think the etiology, we should go for cardioversion. Patient hemodynamically stable, differentiate between narrow and wide KRAS complex. And if it is wide KRAS complex, We can still try vagal maneuvers, adenosine, if it is regular. If it is irregular, we should not use adenosine. We can start with beta blocker, then other antiarrhythmic medications. Okay. So I'll go back now to the cases we discussed so far about white Caris complex. The first case, the 56-year-old, you actually almost all of you got it right. He's 56 or older patient, has hypertension, dyslipidemia, ischemic heart disease. So before seeing the ECG, 95% the chance the white Caris complex we have is ventricular tachycardia. When we look to the ECG, it is white Caris complex, regular, monomorphic. V1 and V6, they are not typical right bundle branch block. So this is one criteria. If you look to the axis, it's left, extreme left axis. If you look to the AVR, it is positive to start with. So the AVR criteria is met. If you look to the lead 2, from the beginning to the nadir, it's more than 50 milliseconds. So all the criteria here is pointing towards a ventricular tachycardia. And yeah, this patient was having ventricular tachycardia for sure. This is his baseline ECG, showed you that there's difference from tachycardia and baseline ECG. So this is not supraventricular with apparency. The second case, actually, most of you got it right also, because this is very typical right bundle branch block, RSR, deep S wave in the inferior leads. We don't see any other criteria. So the AVR is negative. The initial part in lead 2 is sharply positive. So everything is pointing towards SVT with bundle branch block. The patient baseline was actually right bundle. So when the patient developed SVT, of course, he was still having right bundle with the SVT. The third case, the 33-year-old lady with palpitations, although it looks maybe like a typical, because RSRMV1, deep S wave, although the RS ratio here is not huge, but if you look initially to it, you must think it could be typical right bundle, but then, as mentioned actually in the chat, I've seen you got it right. There is clear P wave marching through, so AV dissociation is there. If you look to the AVR, again, sparsely positive. So this is a ventricular tachycardia. And if I ask you, what do you think this tachycardia, where is it originating from if the echocardiogram is normal? What do you think the origin of this ventricular tachycardia? In young female who is excellent. Fascicular VTAC, excellent. We'll discuss actually the VTAC. The white Caris complex is just a brief introduction how to differentiate, but the main talk will be about the VTAC itself. We will the second talk. This one actually, again, most of you actually got it right. 70 years old with hypertension, dyslipidemia, although the age and there is risk factors. But if you look to it, it's irregular. Always just think about VTAC, especially in elderly patient. So this is the baseline actually patient ECG was like this, but not as wide as with the fast rhythm. And this is because the patient was in flecainide. So patient with sodium channel blockers with fast rate, they may have wider Caris complex. But the clue here that the patient is clearly irregular elderly patient. And if you have the baseline ECG, we'll see this almost matching, but wider, more wide Caris complex. The third or the last case, I mean, the fifth one, the 23 years old. This is a pre-excited AFib, as you all got it right. Very common that come in exam, and I'm sure you recognize it and recognize what medication you should avoid. And AV blocking medications should avoid: beta blocker, calcium channel blocker, adenosine, even amiodarone nowadays, procainamide. If the patient is hemodynamically stable, if hemodynamically unstable, then cardioversion. So for the white Caris complex part, the underlying cause of regular white Caris complex tachycardia can be misdiagnosed in up to 10% of patients, even with this using all the ECG criteria mentioned. And if you are not sure with a sustained white Caris complex tachycardia, better to treat it as VTAC till you are sure this is SVT with apparency or other differential diagnosis. And sometimes EP study is essential to have a definitive diagnosis. Any question about the white Caris complex tachycardia?
Assalamu alaikum, Dr. Bandar. I think your voice is mute.
I'm really sorry. Yeah. So I'll go back quickly.
Thank you, Doctor. Yeah.
Yeah. So for ventricular tachycardia, by definition, is a ventricular tachycardia with 3 consecutive beats at a rate of 100 beats or higher, non-sustained when it is lasting less than 30 seconds or not requiring intervention for termination, i.e. hemodynamically stable, sustained VTAC when it is lasting 30 seconds or more or requiring intervention for termination. It can be classified into monomorphic, one morphology during the tachycardia, or polymorphic when continuously changing QRS complex morphology. From the monomorphic, ventricular flutter is one of the monomorphic VTAC. When you have the QRS complex is so fast and we cannot determine QRS complex morphology. Pleomorphic when you have changing in morphology but not continuously changing, like polymorphic VTAC. So there are more than one morphology at the same time or different times, but they are not continuously changing like polymorphic VTAC. Torsad, as you know, it is part of the polymorphic VT when we have twisting around the baseline, and of course, typically in patient with prolonged QT interval. The mechanism of tachycardia, ventricular tachycardia, is the same as mechanism of any tachycardia. Could be impulse formation issues like increased automaticity or triggered activity, early or delayed. The increased automaticity typical for accelerated idioventricular rhythm or idiopathic VTAC. Triggered activity typical for torsade or idiopathic ventricular tachycardia. Re-entry, which is the most common, is conduction issues with leading to tachycardia. Monomorphic VT is the typical example, and VF is another example. When you have a ventricular tachycardia patient, from the diagnosis you are sure there's a VTAC, it's important to differentiate VTAC with structural heart disease or VTAC with no significant structural heart disease or normal heart. A VTAC with a structural heart disease is life-threatening and can happen in patients with ischemic or non-ischemic cardiomyopathy, patient with arrhythmogenic right ventricular cardiomyopathy or dysplasia, hypertrophic cardiomyopathy, or other structural heart disease like sarcoid, for example, or congenital heart disease. Ventricular tachycardia with no significant structural heart disease or VTAC in patient with normal heart. In the past, we call it idiopathic ventricular tachycardia, but now we know the diagnosis is, and usually it's better to avoid this terminology, idiopathic VTAC. It could be outflow tract VT, fascicular VT, annular VT. The classic description for VT with normal heart or idiopathic VT was in monomorphic VTAC, so this is the differential, but now it is including actually polymorphic VTAC in patients with normal heart, like patients with CBVT or long QT syndrome or Brugada syndrome. The ventricular tachycardia patient, they may have symptoms or they may not have symptoms. If they have symptoms, could be mild, like palpitations or just mild shortness of breath, or could be severe, like syncope or even sudden cardiac death. This is a patient who is 56, the same patient I showed you earlier, with the previous history of myocardial infarction, and he's in emergency room, so we all got that it is ventricular tachycardia based on the history, based on the ECG criteria. But the question here, what is the most likely cause for his arrhythmia? Is it atrial tachycardia with right bundle? I think we excluded that. Is it inferior wall ventricular tachycardia, lateral wall ventricular tachycardia, or antidromic? So A and D, already from the first talk, we exclude them, but can you tell where is the source of this ventricular tachycardia? Where is it coming from?
RVOT.
Outflow tract?
Right.
Okay. So think about here. We have two possibilities. This patient with ischemic heart disease, is it inferior wall or lateral wall? We will come actually to the outflow tract in a minute when we talk about, and this, by the way, the VTAC in a structurally abnormal heart. Okay, left and inferior. So if you look to the, it is right bundle-like, so it's coming from the left ventricle. If you look at the inferior leads, they are negative. So activation is going from below up. It's moving away from the inferior leads. So it is coming from the inferior wall of the left ventricle. We'll discuss this in a minute, how to localize ventricular tachycardia in patient with ischemic heart disease or myocardial infarction. VTAC in coronary artery disease, the incidence varies and depends. Patient with ST segment elevation have 3.5% risk of having VTAC, while patient with unstable angina or non-ST segment elevation, about 1%, 0.8% risk of having ventricular tachycardia. And clinical presentation could be tolerated sustained VTAC or sudden cardiac death. If we think about sustained monomorphic VT within the first 2 days of acute myocardial infarction, this occurs in about 3% of the cases. It is associated with increased mortality in the 30 days, but not in 1 year if they survive the 30 days. And mechanism here usually is abnormal automaticity because of ischemia. And usually once they are revascularized, this cause is reversible. If they have a VTAC during the subacute and healing phase of acute myocardial infarction, i.e. 2 days or more after the VTAC, generally associated with reduced ejection fraction, and sustained monomorphic VT within 3 months following myocardial infarction has 40 to 50% mortality at 2 years. There are certain predictors of increased mortality like anterior wall myocardial infarction, frequent episode of sustained or non-sustained ventricular tachycardia, the presence of heart failure. If the patient has multi-vessel coronary artery disease, especially if they are still having ischemia. If it is chronic, the mean time here for developing VTAC after myocardial infarction is 3 years, but can be seen in when they looked at the made it to analysis in 10 to 15 years after acute myocardial infarction. Annual mortality is 5 to 15%. So VTAC could happen early in the first 2 days, could happen after 2 days to a few months, could happen later on, years later after the myocardial infarction. And the substrate for VTAC usually developed over 2 weeks, but there are certain triggers that can trigger VTAC, development of VTAC, like surge in autonomic tone, electrolyte imbalances, especially severe hypokalemia, hypomagnesemia, acute ischemia, or acute heart failure decompensation. All of this can trigger VTAC in patients with ischemic heart disease. And we know this is scar-related, a re-entry mechanism. Remember other cardiomyopathies like dilated cardiomyopathy, ARVCD, patient sarcoid, hypertrophic cardiomyopathy, scar related to these diseases can also lead to re-entry tachycardia and ventricular tachycardia, but the commonest for re-entry, of course, is ischemic heart disease. If we have it, we have to correct identifiable cause like ischemia or electrolyte disturbances, consider antiarrhythmic medications, implantable cardioverter, we'll discuss the indications now, and then catheter ablation if needed. Identifying the source of origin of VTAC in patients with coronary artery disease, one can localize by looking, is it septal or lateral walls, superior or inferior walls, and apical or basal regions of the heart. In the lateral versus septal area, septal and right ventricle will have left bundle branch block-like pattern. So if the tachycardia is coming from the right ventricle or from the septum, typically have left bundle branch block pattern, relatively narrow from the septal area because of parallel activation of the right and left, and that's because of early engagement of the Hess-Purkinje system. In the lateral wall, typically have right bundle branch block pattern and wider QRS complex because of the sequential activation from left to the right ventricle. So remember, if you have left bundle, in left bundle, generally the normal left bundle, patient activation started from the right side. So it could be right ventricular or from the septum. Patient with right bundle, the activation of the heart started from the left ventricle and then activate the right bundle. So right bundle is an indication that the tachycardia is coming from the left ventricle. And if it is really wide, it's likely to be lateral wall. To differentiate between superior and inferior wall, we look to the inferior leads. If the inferior leads are negative, this is superior axis, i.e. it's coming from the source of the tachycardia coming from the inferior surface of the heart. If the axis is inferior, i.e. positive in inferior lead, the tachycardia is coming from the superior surface of the heart. Basal versus apical regions, we look to V1 to V6. In the basal area, activation is going this direction, so you would expect the V1 to V6 to be positive. If it is from the apex, it's moving away from these electrodes, so typically they are negative precordially. So positive concordance, basal area, negative concordance, the apical source of the tachycardia. And to summarize it again, if we have, in the septal and RV, we have typically left bundle branch block. If this origin is superior, we will have inferior axis. The Keras complex would be positive in the inferior leads. If we have inferior source of the tachycardia, we will have superior axis, i.e. negative inferior leads. In the lateral, we will have negative lead 1 AVL and right axis deviation. Basal, positive V1 to, especially lateral, V3 to V5. And apical is typically in S-wave, dominant in V3, 4, and 5. So again, if you have a tachycardia in patient with abnormal heart, especially patient with ischemic heart disease, and you have tachycardia, you can try to localize where is it coming from. Management-wise, in patient with acute ST segment elevation who has ventricular tachyarrhythmia, they need urgent revascularization. So they should go to the cath lab and have revascularization. Start beta blocker prior to the intervention. It's class 2A if the patient is not hypotensive or an acute heart failure, i.e. does not have contraindication for beta blocker. If after revascularization they have ventricular tachycardia early or ventricular arrhythmia early, then you may need to take them to the cath lab again for revascularization, replace electrolytes, beta blocker, and sedation sometimes, and very rare cases you need actually to anesthetize the patient if they have significant recurrent. Just treat them as the same as a patient with electrical storm. If still recurrent via ventricular arrhythmias, one may use amiodarone, lidocaine. Generally, lidocaine is 2B compared to 2A with amiodarone. So we start with amiodarone. If the tachycardia is still not well controlled, we add lidocaine with amiodarone. Then again, deep sedation. If tachycardia is recurrent, then consider catheter ablation. If there is bradycardia, you may consider overdrive pacing, pace the patient faster if it is triggered with BVCs and bradycardia. And then sometimes you may need to go for mechanical circulatory support in very advanced cases. In chronic coronary artery disease, if they are 6 to 12 weeks after acute myocardial infarction, if ejection fraction initially in discharge was 40% or less, we need to re-evaluate the ejection fraction 6 to 12 weeks after acute myocardial infarction. This is from the latest European Society of Cardiology guidelines in 2022. So if ejection fraction 35% or less, and they have New York Heart Association heart failure class 2 or more, then ICD is class 1 indication. If they don't, for example, they are class 1 only, then look to ejection fraction. If it is 30% or less, again, ICD is indicated. It's not class 1, it is 2A, but it still should be considered. If ejection fraction is 36 to 40%, then if they don't have non-sustained VTAC or unexplained syncope, we may just follow them up. So ejection fraction 36 to 40%, still just follow up. If they have non-sustained VT or unexplained syncope, then we may go for programmed electrical stimulation. If monomorphic VT is sustained monomorphic VT is induced, then ICD is indicated. It's 2A. If no sustained monomorphic VT and or unexplained syncope, then we may go for ILR implantation. Actually, there's more and more for implantable lobe recorder implantation nowadays in syncope and in arrhythmias in general. If the patient has sustained monomorphic VTAC in patient with chronic coronary artery disease, typically they present to emergency room months or years later after myocardial infarction with sustained monomorphic VTAC. If it is the first presentation and ejection fraction is 40% or more, and it is hemodynamically stable, you have the option of go for catheter ablation as 2A or ICD implantation or amiodarone. Sometimes they may need combination of these. If ejection fraction is less than 40%, it's class 1 indication to go for ICD implantation. So monomorphic VT in patient with ischemic heart disease, Ejection fraction less than 40%, then ICD is indicated. Catheter ablation is 2B. Usually, if they have multiple ICD shocks, we go for catheter ablation. It is not definitive therapy, but it can minimize the number of ICD shocks. If the patient has a sustained monomorphic tachycardia and he already had ICD, if symptomatic, then we can go for amiodarone. If he's an amiodarone, if he's already in amiodarone, we go for catheter ablation. If he's not in amiodarone, we start amiodarone. If ejection fraction is 40% or more, sotalol can be used. Catheter ablation also, and you see the criteria for all of them. It is class 2A indication for amiodarone, sotalol, or catheter ablation. Now we'll go to the second case, a 14-year-old young female with dilated cardiomyopathy, ejection fraction 25 to 30%. She's a survivor of sudden cardiac death, so already had ICD implantation in place, and she's in emergency room with wide varus complex tachycardia. Of course, looking to the history, it's VTAC 99% of the time. If you look to the ECG itself, it's not typical right or left bundle. And if you look to the AVR is positive. If you look to the criteria in lead 2 is really wide. The initial part, you may see P waves marching through there. Not very obvious, to be honest. But here, for example, so there is all criteria for ventricular tachycardia. But the question here, what is the most likely? What is the origin of this ventricular tachycardia? And we discussed briefly in the previous talk about the origin of ventricular tachycardia, mainly ischemic, but you can apply it to scar-related ventricular tachycardia. Where do you think it is coming from? Is it inferior wall or left ventricular tachycardia? And we already mentioned that it is not supraventricular with aparencia, not antidromic beta. So SEC. Yeah, left lateral, more specific here. Yeah, so if you look at the criteria here, it's like right bundle branch or right bundle-like morphology. So it's not coming from the right side, it's coming from the left side. And as mentioned here, actually the 1 and AVL, they are negative. So it's coming from the lateral wall of the left ventricle. So it's left ventricular, is not right ventricular. And not coming from the inferior, because if you look at the inferior leads, they are positive. So it's coming from the superior part, not inferior part of the heart. This is the baseline ECG for the same patient. She has sinus rhythm with actually IVCD more than left bundle, because if you look to the V5, V6 is not the RSR pattern, so it is different from the tachycardia. Ventricular tachycardia in patients with dilated cardiomyopathy may present as multiform BVCs or ventricular bigeminy or non-sustained ventricular tachycardia, which is common, by the way, to have BVCs in dilated cardiomyopathy and non-sustained VTAC in 80 to 95%. The ventricular tachycardia depends on the heart failure status. So patient with class 1 to 2, 15 to 20% may have non-sustained ventricular tachycardia. More advanced heart failure, like class 4, 50 to 70% of the time they may have non-sustained ventricular tachycardia. It's more common in advanced heart failure and may arise from the myocardium or could be macro reentrant bundle branch block tachycardia. We know the first actually therapy to prevent arrhythmia is to put them in appropriate medical therapy. There is reduction in mortality with ACE inhibitors, ARBs, beta blocker, and mineralocorticoid inhibitors. And also there is reduction in mortality with ARNI, with SGL2 inhibitors. So in dilated cardiomyopathy, to prevent arrhythmia, the first thing is to start them in optimal medical therapy. How to manage tachycardia in those patients. There is more and more, by the way, now role for genetics and for cardiac MRI in patients with dilated cardiomyopathy or hypokinetic non-dilated cardiomyopathy. They are treated the same. So cardiac MRI is class 2A indication to do them. If there is suspicion and cause of the dilated cardiomyopathy, then we treat according to the specific cause. If it's ARVCD, for example, treat as ARVCD. If it is sarcoid, treat as sarcoid. If it is Chagas disease, treat as Chagas disease. If there is no clear reason, then look to the family history. If they have family history of dilated cardiomyopathy or family history of sudden cardiac death in young people in first degree relative, or even if they have conduction system problems like AV block in younger age, less than 50, class 1 indication to do genetic testing. If they don't have it, it's still 2A, so it should be considered also. So genetic testing is recommended in patients with dilated cardiomyopathy. If there is pathogenic mutation in lamina, which is high risk, and the 5 years risk of ventricular arrhythmia is more than 10%, and left ventricular ejection fraction less than 50, or non-sustained VTAC or AV conduction. If you have this, ICD implantation is class 2A indication. If they don't have it, then just annual re-evaluation for arrhythmia risk. If the patient has left ventricular ejection fraction 35% or less, this is an indication for ICD. It is the same as in the past. It is downgraded to 2A, but it still should be considered. If the ejection fraction 36 to 50%, and they have 2 or more risk factors, namely unexplained syncope or pathogenic mutation, or late gadolinium enhancement on MRI, or inducible sustained monomorphic VT at programmed electrical stimulation, if they have 2 or more, there is indication for ICD. If not, we look to if they have unexplained syncope. If they have unexplained syncope, we have 2 options: one, to go for ILR implantation, or to go for programmed electrical stimulation. And if it is positive for sustained monomorphic VT, to go for ICD implantation. If they don't have this, we just go for regular follow-up. The next patient is a 45 years old male, is in emergency room because of dizziness, palpitations, blood pressure 120/74. In the top here, we have the ECG during tachycardia. In the bottom, ECG post tachycardia termination. So what do you think? What is your diagnosis? I'll give you a minute to look to the ECGs and see what do you think the cause of his wide Caris complex tachycardia. So what do you think? Do you have a specific diagnosis in this patient? Let me go to the next one. So is it arrhythmogenic right ventricular cardiomyopathy, outflow tract, idiopathic fascicular VT, or antidromic AV reciprocating tachycardia? I'll go back to the ECG. Give you more time to analyze it. So it's between A and B. A is arrhythmogenic right ventricular cardiomyopathy. B is outflow tract VTAC. Yeah, T wave in V1, 2, 3. Okay, this can give you a clue. So if you look at the wide Caris complex tachycardia, I did not give you any clue if this is normal heart or abnormal. He's a young male patient, but if you look, this is not a typical left bundle. Let's say there is deep QSR wave, but the morphology here is different. There is negative, by the way, AVR. Lead 2 is not very clear, but if you look to the inferior surface of the heart, it is negative, so it cannot be outflow tract, because in outflow tract, you expect inferior leads to be positive. Here, inferior leads, they are negative. And diagnosis in this patient, why I presented the baseline ECG, because it's actually more diagnostic than the ECG during tachycardia, because if you look to the ECG, there is T wave inversion V1 to V3 in a patient with out bundle branch block. This is one of the major diagnostic criteria for arrhythmogenic right ventricular cardiomyopathy or dysplasia. Another one that you should try to look for is epsilon wave. It is not in this patient, but you may see it in other patients. So if you have wide Caris complex tachycardia, young patient, baseline ECG is showing T wave inversion V1 to V3. You have to think about arrhythmogenic right ventricular cardiomyopathy or dysplasia. Arrhythmogenic right ventricular cardiomyopathy or dysplasia is a progressive disease, replacing normal myocardium with fibrous and fatty tissue. Usually involves the right ventricle initially, but late ventricle and septum may be involved late, and it's bad prognostic sign. They have what you call triangle of dysplasia, can be inflow, outflow, or apex. Mostly in young adults, 80% of patients with ARVCD, they have the diagnosis in less than for the age of 40 years, more common in males than in females. Again, it's inherited progressive disease. And you see there, the muscle tissue is replaced with fatty and fibrous tissue. This is a needed for re-entry and tachycardia, leading to instability and ventricular arrhythmia and risk of sudden cardiac death. Typically, it is inherited as autosomal dominant, but variable penetrance, and it is disease of desmosomes. Desmosomes connect the myocardial cells together, and if there is damage of the desmosomes, then we start to have fibrous and fatty replacement in between the myocardial cells. The estimated prevalence is between 1 in 5,000 to 1 in 1,000. So it's not a common disease, but it's life-threatening. And you know the revised task force criteria in 2010, if you have two major or one major, two minor diagnostic, this is definitive diagnosis, borderline, one major, one minor, or three minor. Well, possible if it is one minor or, one major or two minor. And the criteria depends in the presence of global or regional dysfunction of the RV. Based on echo and MRI, there are special criteria or RV angiography, tissue characterization by endomyocardial biopsy, repolarization abnormalities, as in the patient I showed you, the T-wave inversion in V1 to V3, the depolarization or conduction abnormalities, the epsilon wave or late potentials in signal average ECG, which is minor, epsilon wave is major, arrhythmias, left bundle, like morphology, ventricular arrhythmias, family history of ARVCD or mutation that is known to cause ARVCD, or premature sudden cardiac death in the families. So remember the criteria, and if the patient has two major or two minor, two major or one major, two minor or four minor, he's definitive for ARVCD. Just as a reminder, the thing that look to ECG is the T-wave inversion V1 to V3, the presence of epsilon wave. This patient has an epsilon wave. There, as you can see, sharp deflection here in the ST segment. This is major and this is major. So this patient has two major criteria. And there is another one actually here in the ECG. If you look, there is a BVC with left bundle, and it is not superior axis, it is inferior axis. It's superior axis, not inferior axis, not coming from the outflow tract. It's negative in the inferior leads. So this is another hint that this patient has BVCs originating from the inferior surface of the heart, not from the outflow tract. Because this is the main differential diagnosis, is to differentiate ARVCD from outflow tract with the normal heart. Abnormal signal average ECG, then the typical VTAC is left bundle morphology, of course, because coming from the right side. In echo and MRI, you may have dyskinetic or bulging, or fibrofatty is less important nowadays and may not be seen quickly, but the most important is the presence of aneurysmal dilatation in the right ventricle, like this patient. The clinical presentations, the clinical presentation for patients with ARVCD, they may present with fatigue, atypical chest pain, palpitations. However, syncope and sudden death is not uncommon. Ventricular arrhythmias occur in about 23% of the patient. The severe disease, almost all of them, they will have some types of arrhythmia, could be sustained or non-sustained. May occur during exercise. High-risk features, if the ARVCD developed in young age, especially with children, usually have poor prognosis. Patient with recurrent syncope, previous cardiac arrest, or hemodynamically unstable VTAC, LV involvement, certain types of ARVCD based on the genetic testing. The wider the Keras complex is aspersion, or increased Keras dispersion, it's increased risk of sudden death in patients with ARVCD. Management is pharmacologically by beta blocker, sotalol or amiodarone. We may use class 1 or 1A or B, but it is not that effective, and better to avoid it if there is significant, of course, structural heart disease. Radiofrequency ablation can be used, but typically, if you ablate one focus, they may have another. So generally, radiofrequency is in a patient who already had ICD and multiple ICD shocks. We don't do it as prevention to avoid putting a defibrillator, which is indicated in high-risk patients. Patient with ARVCD evaluation should include cardiac MRI, and in definitive cases, genetic testing and genetic counseling is recommended because, as I mentioned, this is familial disease, autosomal dominant mostly. There's autosomal recessive forms like Knox's disease and others, but it is mostly autosomal dominant. Avoid high intensity exercise. It is class 1 recommendation. So remember, if a patient ARVCD you see in the clinic, you should advise him against high intensity exercise because this causes progression of the disease. In patient with genetic testing, also it is recommended to avoid high intensity exercise. It is 2B, not class 1, like patient already with ARVCD. Beta blocker may be considered in all patients with definitive diagnosis of ARVCD, 2B indication. For primary prevention of sudden cardiac death, it should be considered in patients with ARVCD, and syncope looks like arrhythmic syncope, sudden onset with no prodromal symptoms, not typical for vasovagal or other syncope, and should be considered in patient with definitive diagnosis of ARVC and severe LV or RV dysfunction, or if they have moderate dysfunction with positive programmed electrical stimulation or non-sustained ventricular tachycardia. All of this 2A should be considered. And it is 2B if patient with ARVCD with highly suspicious ventricular arrhythmias and programmed electrical stimulation. It's 2B to be used in those patients with ARVCD and high suspicion for ventricular arrhythmias, but not documented ventricular arrhythmias. Secondary prevention is easy, like any other patients. If they already have hemodynamically unstable VT or VF, i.e. survival of sudden cardiac death, they have an indication for ICD. Patient with ARVCD and non-sustained or sustained ventricular tachycardia, they should have actually beta blocker therapy. Patient with ARVCD who has recurrent symptomatic monomorphic VT or ICD shocks, catheter ablation should be considered. And again, patient who with an indication for ICD, device therapy with ATP is recommended. So that, i.e. subcutaneous ICD is not recommended in those patients to start with, because many times this tachycardia is responding very well to ATP, anti-tachycardia basing. I remember one patient, young with ARVCD, has like 400 ATP in one day. He was not symptomatic, but if he was having only shock therapy, remember how many shocks he will receive during that day. So ATP is very efficient in those patients with ARVCD. So generally, when implant transvenous ICD, and we programmed ATP on. Again, secondary prevention, ICD should be considered in ARVCD with hemodynamically tolerated sustained. Even if it is hemodynamically tolerated, it is 2A indication to put an ICD. Again, symptomatic patient with despite beta blockers. And then we may add antiarrhythmics like sotalol or amiodarone. And it's important to screen patient with first degree relative and patient with ARVCD, generally by doing ECG, echocardiogram, and of course genetic testing. Moving now to hypertrophic cardiomyopathy, one of the other structural heart disease predisposed to sudden cardiac death and ventricular arrhythmia. It is autosomal dominant. There are mutations in cardiac sarcomeres. The heavily variable clinical presentation, but they may present with sudden cardiac death. And sudden cardiac death can happen in young patients with no previous symptoms. So primary prevention is very important in those patients. They may have symptoms, mostly actually of heart failure due to diastolic dysfunction or left ventricular outflow tract obstruction. Risk stratification is very important, and it depends on the clinical and genetic predisposition. The beta myosin heavy chain is one of the common mutations in those patients, as you know. The troponin mutations have high risk for sudden cardiac death, irrespective of the left ventricular hypertrophy degree. Mortality overall is about 1% per year, and sudden cardiac death is 0.2% per year. Those patients even can present, as I mentioned earlier, with mild or no symptoms, and common in adolescents and before the age of 30 to 35 years. The predominant mechanism here is VTAC or VF. However, there are rare cases of asystole. They may develop rapid atrial fibrillation. Actually, atrial fibrillation very common in patients with the hypertrophic cardiomyopathy because of diastolic dysfunction and dilatation of the left atrium. And they may have electrical mechanical dissociation, of course. So that's why sometimes they may have a defibrillator, they still not benefit from it. But this is not the common. The commonest mechanism is VTAC, VF, where ICD is effective in preventing sudden cardiac death in those patients. So patients with hypertrophic cardiomyopathy, cardiac MRI with late gadolinium is recommended, of course. Genetic counseling and testing is important. Participation in high-intensity exercise should be discouraged. Risk stratification for primary prevention. You know the European Society of Cardiology risk score, you should look to it. And if it is very high, more than 6%, then it is 2A to implant an ICD. If it's in between 4 to 6%, then look to other risk factors like significant late gadolinium enhancement, i.e. 15% or more of the left ventricular mass, or ejection fraction less than 50%, or abnormal blood pressure response to exercise, or apical aneurysm in the left ventricle, or genetic mutation that makes them high risk. Then it's again 2A indication to put ICD on those patients. If they are less than 16 years of age, and estimated 5-year risk of sudden death 6% or more, ICD also should be considered. Secondary prevention, any patient with the previous hemodynamically unstable or VTAC or VF, of course, this is like any other secondary prevention criteria in any all diseases. In patients with hypertrophic cardiomyopathy presenting with hemodynamically tolerated sustained monomorphic VT, again, it is 2A to put an ICD in those patients because it can turn at times to be hemodynamically unstable. And in patients who have hypertrophic cardiomyopathy, recurrent symptomatic ventricular arrhythmias and recurrent ICD therapy, antiarrhythmic should be considered. And catheter ablation also might be recommended in patients with hypertrophic cardiomyopathy. It is 2A. And of course, first degree relative should be screened with ECG echocardiogram. Briefly, other structural heart disease that predispose to VTAC, left ventricular non-compaction. In the past, it was dilemma to put an ICD in those patients to look to ejection fraction or other criteria, but in the new guidelines, they should be treated or managed the same as dilated cardiomyopathy. So if you have patients with left ventricular non-compaction, manage them the same as dilated cardiomyopathy. Patient with cardiac amyloidosis, ICD should be considered in patient with light chain amyloidosis or transferrin-associated cardiac amyloidosis who have hemodynamically not tolerated VTAC, again 2A. In patient with cardiac sarcoidosis, ICD implantation for primary prevention in patient with ejection fraction less than 35%, so the same criteria for dilated cardiomyopathy. It is an indication to do if the patient has indication for pacemaker, like high degree AV block, it is recommended to implant ICD rather than pacemaker, regardless of the ejection fraction. So patient with sarcoid has AV block, high grade AV block, need the device, implant transvenous ICD rather than pacemaker because they have high risk of developing arrhythmias. And when they have conduction system, they are higher risk to develop ventricular arrhythmias. In patients with sarcoidosis, ejection fraction 35, more than 35, but significant late gadolinium with cardiac MRI after resolution of the acute phase, ICD also indicated. So late gadolinium enhancement, even if ejection fraction more than 35% in sarcoid patient, might be an indication or should be there should be a consideration of ICD on those patients. It's 2A indication. Patients with sarcoidosis, ejection fraction 35 to 50, minor late gadolinium enhancement. Then programmed electrical stimulation is class 2A indication. Patients with ejection fraction 35 to 50 with sarcoidosis with inducible sustained monomorphic VT, ICD is 2A indication. Secondary prevention, again, patient who already had VTAC or VF cardiac arrest, it's class 1 indication. Patient with cardiac sarcoidosis, recurrent symptomatic ventricular arrhythmias, they should be put in antiarrhythmic medications. Catheter ablation is 2B indication in patient with sarcoidosis. VT in patient with congenital heart disease, this is a special group of patients. I'm not going to discuss them, but remember they have high risk of having wide Keras complex tachycardia. Predictors for sustained VTAC is different from the populations that we have in patients with other structural heart disease like the ischemic heart disease or dilated cardiomyopathy. It depends on the duration of the Keras complex. When it is 180 or more, rapid increase in Keras duration after repair or dispersion of the Keras complex intervals, the presence of batch in the right ventricular outflow tract and others. So remember, if you have a patient with congenital heart disease, there are certain risk factors, and actually in the new guidelines, it's a different tetralogy of Fallon repair, for example, from others. So look to the specific disease and their predictors. Although they have wide Keras complex, but the response to the ICD therapy is less compared to patients with ischemic heart disease and dilated cardiomyopathy. So they have their own specific criteria for ICD implantation. Now let's move from these patients to another category of patients. We have here a 25-year-old female who has 2 hours rapid palpitations at home, and she's in emergency room with this ECG. So 25-year-old, and echocardiogram is normal. What is your diagnosis? Is it, or actually, what will optimal manage? So just give me what do you think the diagnosis, and then the answer here, what is the most optimal approach to manage this patient? So what do you think the diagnosis initially? A VTAC, what kind of VT? And from the answers here, what is the most optimal approach? Okay, right ventricular outflow tract. E, yeah, excellent. So you got it right. The diagnosis here is right ventricular outflow tract. If you look to the ECG, it is like left bundle-like, and it is positive in inferior leads. We have young patient with structurally normal heart. So the VTAC from the history is unlikely. But when we look to the ECG criteria, it is actually goes with the VTAC because the morphology itself, and because we have this morphology typical for condition which is the outflow tract VTAC. If you concentrate that there may be a AV dissociation, you can see P wave here. You see another P wave there. So there's AV dissociation. So the ventricular tachycardia. Or the history initially does not sound a VTAC, but when you look to the ECG, it's like a VTAC. And the same, we have a condition in young people typically present with the same this ECG, which is left bundle and inferior axis, which is outflow tract VT. Although EP testing and catheter ablation at the first line, but this is the most optimal, and most of the patients, when they have this VTAC and they don't respond to arrhythmic or they don't want to be on antiarrhythmic medications, we go for EP testing and catheter ablation because of the high success rate. Okay, this is another case, a 16-year-old with palpitations for 8 months, no syncope. He was sent actually as a SVT with apparency for further management with EP study. So what do you think the diagnosis here? ICC, monomorphic VT from right ventricle. By the way, the ECG layout here is different. You have the limb leads here, 1, 2, 3, AVR, AVL, AVF, and this is V1 to V6. This is from another hospital, so this is their way of doing the ECG. They have the limb leads, and then they have the precordial leads. So the V1 is here, and these are the limb leads. So the good thing that they recovered that is a ventricular tachycardia, because as I mentioned, the Keras complex here is relatively narrow, and that's why actually he was referred as narrow Keras complex tachycardia with apparency for EP study and ablation. But if you look carefully, you see clear P wave, so there is AV dissociation, and actually most of you will start to get it right now. it is the monomorphic VTAC coming from the left ventricle. Why? Because if you look to the V1, this is RSR, like right bundle, so it's not coming from the left ventricle, not coming from the right ventricle, it's coming from the left ventricle. In young patient, this is characteristic for what we call fascicular VT. So here the history was not, but if you look to the bundle branch block morphology and the AV dissociation, this is actually pointing that is a ventricular tachycardia. In young patient, I should mention that his echo was normal. So again, VTAC in normal heart, outflow tract is common one, then followed by fascicular VT, which is this case. So idiopathic VT, and what we used to call idiopathic VT or VT with no significant structural heart disease, accounts for about 10% of VTAC. And typically those are patients with VTAC, but they have normal ECG, echocardiogram, and cardiac catheterization. And now ideally we should have MRI, because MRI can show some abnormalities that we did not detect by echocardiogram. Prognosis is generally good, except in inherited arrhythmias. Inherited arrhythmias is not topic for today, but maybe we can discuss it later. The good thing about VT with structurally normal heart that most of the time is amenable to ablation. So prognosis is good, unless it is inherited arrhythmia and amenable to ablation. If we think about the idioventricular tachycardia, could be monomorphic, and this is what I mentioned classically, that when we mention idiopathic VT or fascicular VT, idiopathic VT or VT in normal heart, we look to this one, the monomorphic VT. Outflow tract could be from right ventricular outflow or left ventricular outflow or aortic cusps. Fascicular VT, whether from anterior or posterior fascicle, or septal VT, or adrenergic monomorphic VT, which is uncommon, or annular VT, tricuspid, or mitral. Polymorphic, think about inherited arrhythmias, long QT, short QT, Brugada, catecholaminergic VTAC, corticolinergic polymorphic VT, CBVT, or idiopathic VT or VF. Those patients with normal heart, they may present with frequent BVCs or repetitive runs of non-sustained VTAC or sustained ventricular tachycardia. The common one is outflow tract, which is our first case I showed you here in normal heart. It's commonly coming from right ventricular outflow tract 80% of the time, and common in females in their 3rd to 5th decade of life, may present as non-sustained repetitive monomorphic VT or paroxysmal VT during exercise. Left ventricular outflow tract is 10%. If you look at the outflow tract anatomy, it's very complex. We have the right ventricular outflow tract, we have the left ventricular outflow tract, aortic cusps, and then also we have the aortic valve itself, very close proximity. So the VTAC from outflow tract can happen from the outflow tract in the right side, which is the commonest, 80%, or from the left side, or from the aortic cusps, or sometimes from the proximal part of the pulmonary artery, less commonly. The mechanism here is triggered activity due to cyclic AMP delayed after depolarization, typically exercise induced, but can present at rest. Right ventricular outflow tract characterized by left bundle in V1. Again, inferior lead is positive, of course, in the outflow tract, but late transition, so R wave more than S in V4, 5, or 6, late transition. The left ventricular outflow tract characterized by early transition, R transition V1, V2. If you have R wave transition in V3, still could be right or left ventricular outflow tract. By statistics, is more to be like, but still you cannot be sure if the R wave transition is in V3. So they don't have a structural heart disease. They may have no symptoms, or they may have symptoms related to palpitations. Symptoms may present at rest or with exercise, or high catecholamine intake or caffeine, high catecholamine state, or caffeine. May respond well to vagal maneuvers and carotid massage and adenosine. So that's what we call adenosine-sensitive ventricular tachycardia, is the outflow tract VTAC. And adenosine, if terminate White-Carse complex tachycardia, it could be still SVT with apparency, or it could be adenosine-sensitive, which is the outflow tract VTAC. Typically, management is beta blocker or calcium channel blockers, and non-responders, they may need class 1 or class 3 antiarrhythmic medications. Catheter ablation is very successful. Success rate is about 90%. The second category, which is the fascicular VTAC or idiopathic left ventricular VTAC, the other name is verapamil sensitive VTAC. So adenosine sensitive is the right ventricular outflow tract. Verapamil sensitive is the fascicular VT. Again, typically happens in young individuals between age of 15 to 40 years of age. Male predominance at 60 to 80% of the cases, they are males. Most of the episodes occur at rest, but may be triggered with exercise, stress, or beta agonist. Is a re-entry mechanism. Commonly coming from the posterior fascicle. So we have in the left bundle, we have the anterior and the posterior fascicle. Commonly the entry here is in the posterior fascicle. 90-95% of the time. So they have right bundle branch block and left axis, because if the activity is coming from here up, we will have it positive in lead 1, negative in inferior lead, i.e. left axis deviation. Anterior fascicle is less common, 5 to 10% of the cases. They have right bundle branch block morphology, but they have right axis deviation. Rare variant is the high septal fascicular VT. And in high fascicular VT, the Caras complex is narrow and the axis is normal. It is paroxysmal VTAC. It is the re-entry in calcium-dependent Purkinje vascular fibers. Symptoms may include palpitations, fatigue, dizziness, syncope or pre-syncope. Syncope and sudden death, very, very rare in fascicular VT. So that's why we consider it as benign course. Most of the time happened at rest, can be triggered with exercise, and it is verapamil sensitive, as I mentioned. In the cath lab, actually, what we do when we induced it, by the way, it can be induced with atrial pacing. This is exceptional to other VTAC. So if you induce VTAC in the cath lab with atrial pacing, this is more characteristic for fascicular VT. And when we inject verapamil, you see them slow gradually and then terminate it. Ablation is good for those patients. But usually we start medical therapy. If they don't respond, then we go for catheter ablation, success rate more than 80%. The third category, annular VT, is much less common, and they are actually managed the same as outflow tract. We had good prognosis, so we would not bother you with the mitral annular or tricuspid annular VTAC. Now moving to patients with irregular tachycardias. So 23 years old female presented in emergency room after starting antibiotics for wound infection. What do you think the diagnosis here? Yeah, I've seen one long QT again and Torsade. Yeah. Okay, excellent. Do you notice here QT is very prolonged RNT, young patient, antibiotics, you should think about long QT syndrome, precipitating polymorphic VTAC. And this patient has typical Torsade later on, but it started as polymorphic VT and then Torsade. So if you have patient with polymorphic ventricular tachycardia, if this is exercise induced, you should think about CPVT or ischemic ventricular fibrillation or incidental polymorphic VT. If it is not exercise induced, the first thing to rule out is long QT, because one of the commonest. If the QT is prolonged, we are dealing with Torsade like this patient and manage as Torsade T-point. If they don't have long QT, look for organic structural heart disease. If they have this ischemic ventricular fibrillation or polymorphic Purkinje triggered is most common, is a likely diagnosis. If they don't have a structural heart disease, think about channelopathies like Brugada or short QT syndrome, or unknown etiologies like idiopathic VF or malignant early repolarization or malignant idiopathic RVOT VT, which is again very rare, or drug-induced polymorphic VTAC. Long QT syndrome, remember, it could be congenital, drug-induced, bradycardia-induced, post-infarction, or patient with Takasubo syndrome. This is transient. You have seen many cases, or few cases, to be honest. Few cases of Takasubo, they develop polymorphic VT. And once they are controlled, they don't have the tachycardia, and they are doing well in follow-up. Once the ejection fraction improves, there is no indication to put a defibrillator. Electrolyte also, hypokalemia, hypogonadism, and sometimes food-induced long QT syndrome can be of the differential diagnosis. So patients with the polymorphic VT, of course, they need unsynchronized defibrillation. And once arrhythmia terminated, look to the ECG. If they have QTC 500 millisecond or more, then we should treat as long QT with magnesium infusion, correct electrolytes, stop QT prolonging medication, and if torsade recurs, then we manage accordingly by correcting electrolytes still. If they are bradycardic, increase the heart rate, and sometimes antiarrhythmic like lidocaine. And of course, if there is no reversible cause and they have already VT arrest, at the end they will end up with having ICD. Like our patient actually, she had cardiac arrest later on in local hospital, so she needed a defibrillator. QTC would not prolong, then think about acute myocardial infarction and ischemia, cardiomyopathies, CBVT. So you have to do evaluation for ischemia and cardiomyopathy, and you may consider amiodarone and beta blockers. Okay, any questions so far? Okay, that's actually the end of my presentation. Thank you very much for your time and for listening. And if you have any question, I'll be happy to answer. يعطيكم العافية، شكرا جزيلا.